Can you come a bit closer? Thank you very much. Can you come a bit closer?
Yeah, so my topic for presentation is stapler stuck during sleeve gastrectomy, a nightmare intraoperative complications to deal with. So these are my credentials, which respected sir has already told about. My mentor, Professor Dr. Mohit Bhandari, and Professor Dr. Manuel Galvanito, who taught me how to do endoscopic sleeve gastroplasty in patients like that. I have been invited to become a visiting bariatric surgeon at Seychelles, East Africa, where I have operated 5 bariatric surgeries and rest of the minimal surgeries over there as well. These are my case mix disclosures regarding all the cases which I have performed in 2 to 3 years. Mostly of sleeve gastrectomy, because we have planned very few cases to perform a bypass surgery, but mostly we have converted into sleeve gastrectomy because of the liver condition intraoperatively finding. And various cases like most of the bypass surgeries like SADI-S, SADI and SAPI also. I have no any conflict of interest in that. So starting with the introduction, as we all know, the number of laparoscopic sleeve gastrectomy performed annually as a primary bariatric procedure has significantly increased all over the world. According to many published studies, LSG has proved to be well tolerated and effective, and with a significant reduction of obesity-related comorbidities. Earlier it was said that only bypass surgery used to help in making the resolution in comorbid conditions, but with our data and with our experience, what we have seen that with simple sleeve gastrectomy also, most of the people used to have good resolution of their comorbid conditions like diabetes and hypertension, hypercholesterolemia and other things as well. Surgical staplers have been used to divide and approximate tissues for the decades. The first surgical stapler was developed in 1908 by Victor Fisher and Human Hunt. Now in LSG, the surgeon depends on stapler for creation of a small gastrectomy. Without endo-GI stapler, there is no any bariatric surgery. We are trying to develop some of the procedures like SNAP, which is called a single neodymium anastomotic procedure, in which we have operated some 20 patients with a magnet. And the market has been dominated by 2 companies basically, Jasicon and Medtronic. And there are smaller stapler companies trying to break into this market, but it is very difficult as surgeons become comfortable with one of the devices and know that these devices have the outstanding safety department. So, starting with my case detail first, I have operated one patient of 33 years old male with known case of osteoarthritis, sleep apnea, hypothyroidism with weight gain leading to morbid obesity causing changes in lifestyle. His weight was 164. We tried to convince the patient to have a mini gastric bypass, but patient already got convinced by the Google first, and then he came back to us and he said that no, I want only sleeve gastrectomy. So I said, okay, we will respect your decision and we will perform the sleeve gastrectomy only. The BMI of the patient was 51.76, so we selected the patient for laparoscopic sleeve gastrectomy. Patient did not have any other comorbid conditions like diabetes or any other hypertension issues. No any previous significant surgical history. Now, the endo-GI stapler which we used and which got stuck at the first fire was Meryl Trio 60 mm black window. This was my port position which I have made in the patient. 12 mm port was supraumbilically put, and 110 mm port was placed in the mid axillary line, and two 5 mm ports were put in the left hypochondrium and the right hypochondrium. This thing which you are seeing right now, the artery fossa which is clipped with instrument that we have developed as a liver retractor. We have taken a Karl Storz instrument of 45 cm. We have removed one of the shaft of that which was not of use, and then we have made it as a liver retractor in that. So no need to put a Nathanson over there. So I'll start with sorry. Yeah, so this was my case detail which we have operated, and then the first fire only after doing the gastrolysis and other aspect, we have faced this And it was when you start your bariatric journey, and when you face for the first time like this only, you will think about leave bariatric and go to somewhere else. It's not my branch. So you really have to be experienced with the one who has done most of the cases, including the complications. My mentor always used to say only one thing, that doing a sleeve gastrectomy will never make you a bariatric surgeon. How to manage the complication of sleeve and how to manage the rest of the bypass surgeries, then only you are called as a bariatric surgeon. So after doing all the what is called as methods of removing this stuck stapler, we were tired of removing this stapler, and what we have thought that if this stapler was stuck near the last firing at G junction, then the patient would have been converted to a Roux-en-Y gastric bypass or a esophagogastrostomy. But we were lucky enough that this stapler was stuck at the first fire only, near the posterior angularis. So after manipulating and after doing all the things, it was see, we are trying to just open the stapler and we are trying to just do whatever the procedures which we can do over it. We are trying to just take it back, and this is with the black reload, that's 60 mm. So you can feel that how much thick tissue it was there. That a black reload can also got stuck in that. Okay, so I'll just try to make it fast. One second. Sorry. I'll try showing you in this so that I can make it fast. So after manipulating in all the aspects, what we did, we changed our 5 mm port to 12 mm port near right hypochondria. Okay, and we placed another endo-GI stapler of Johnson & Johnson, and we fired it medially just to the stuck stapler. And it is a very important aspect that why we have to manipulate and we have to fire the staplers on the bougie. You have to be very away from the antrum part, because this is the most common place where you used to get obstruction. So after the application of this, we got it first fired, and then we put an GCT, that gastric calibration tube, so that we can check it out that whether the patient is having any obstruction or not after having this medial fire or not. And then subsequently, we manipulated our stapler cranially, and we fired the subsequent staplers up to the gastroesophageal junctions. We tried to remove the rest of the stapler, the stapler and the tissues over it, and we have taken this tissue and the stapler in toto from the umbilical cord. So this is how we have managed, and it was completely fine after that. I'll show you. So this is how we have progressed up to the further staplers, further firings, and yeah, the patient is doing well with no any obstruction. We did a post-op endoscopy as well. There was no any obstruction in that, and patient has lost a tremendous amount of weight and is very happy. Now on this platform, I would like to show you one of my videos as well, where I have performed mini gastric bypass. I'll just click hardly half of a minute. After decompressing of the stomach, we did the first firing at the opposite of the incisura angularis, and subsequently we made a gastric pouch up to GE junction over a 36 French bougie. This procedure took me almost 35 to 45 minutes to operate. So this is the gastric tube which we have made, and after we did some stapler hemostasis with some of the titanium clips LP300. We did a posterior gastroscopy in this patient like this, and after doing this, you are seeing the blue tip that is called as the GCT tip. We have lifted the transverse colon and we have started tracing the small vowel from DJ flexion. We have taken 180 centimeter of jejunal loop that is called as the mediopancreatic limb. We have placed in a reverse in a C fashion, and we have just made an enterotomy and just we did a gastrojejunostomy in this patient. And now we started closing the enterotomy part with endostitch. This is my personal favorite instrument because this is the one instrument which used to make you very comfortable during surgeries. So we always used to start with the coronal sutures first. We used to secure the coronals first because that is the most important site for any leaks and other things. So after doing the coronal, we started with the cranial end and we performed gastrojejunostomy. So this is how it looked at the last. With minimal bleed, and the patient lost a tremendous amount of weight and the resolution of comorbid conditions after that. So yeah, the discussion. An increased number of bariatric procedures will be associated with an increased number of complications. The creation of the gastric tube using staplers is the key element during LSG and can be associated with complications such as stapler misfiring. The management in this case requires restapling of the stomach using another stapler, leaving the locked stapler in place as we have already seen. Suture reinforcement would be result in the stenosis of the gastric tube. So I will not take much of my time. These are the data which showed the jasicon and Medtronic, what is called as the malfunctions. The conclusion: stapler misfiring during LSG can be dreadful but manageable complications. Surgeons who perform this challenging surgery need to manage this complication. And training of the operative staff on the proper use of device is critical to minimize potential significant complications for recovery. So let's talk about obesity. Thank you for your patience listening.
Thank you so much, sir. Now we'll take a few compliments from the chairpersons.
Meanwhile, if the question is getting asked, I'll just play one of my videos so that we can ask the questions and regarding it. This is how my team setup we used to perform it. Any questions, sir?
So thank you very much for a wonderful presentation. And there must be queries, so we can carry on.
We can ask the audience if you guys have any question for sir.
So one question. From the house.
Thank you.
We'll move on.
Sir? What we can reduce the bariatric surgery? Sir, there are few what is called as no one wants to go for a no, definitely it's a life. The problem with this is that the compliance of the lifestyle. No one wants to have the compliance of that. So thank you, Jasicon, for giving me the opportunity to present my topic regarding bariatric surgery. So thank you. Thanks a lot.
Wonderful, really impressive. Thank you very much.
Thank you, sir. Now I would like to call upon Dr. Nirupam Sinha to please present the paper.